Okay, almost time to celebrate the last of our central nervous system lecture, part 5, and this one deals with analgesics. If you recall, an means against, algesia is feeling, so we're talking about medications that are going to work against feeling. Your objectives for this section of the lecture are that you should be able to describe the sources of opioid analgesics, discuss the therapeutic and adverse effects of opioid analgesics, discuss administration, absorption, and metabolism of opioid analgesics. I will say that right before the end of this lecture. And describe the advantage of selecting acetaminophen over aspirin. And your last objective is that of being able to describe the primary side effects associated with aspirin and anti-inflammatory drug usage. So we're talking about medication going to affect pain. Therefore, a little bit of background on pain before we get into the medications themselves. Sensation of pain is comprised of at least two elements. You have local irritation to the nerves, stimulation of those peripheral nerves, and then the recognition of the pain itself, which happens inside the brain. So the nerve endings are located in the skin, muscles, joints, bones, and viscera of the body. And they respond to the tissue injury with a painful stimulus. When there's no pain, there's no injury, or when there's no injury, there's no pain and no stimulus. Now what happens is usually prostaglandins, histamine, bradykinins, serotonins are neurotransmitters that are released and trigger these receptors that are in the skin. These receptors then alert the brain to the intensity of the pain by increasing the frequency of the signals that are sent to the spinal cord and then to the areas within the nervous system, or the central nervous system. So then the pain signals have been transmitted from the skin or receptors or the muscle or the bones or the joints through the spinal cord. And then it is consciously experienced by the brain. So whenever you're having pain, it's got to go through this track of a stimulus, which goes to the receptor, which then goes to the spinal cord, which goes to the brain, which then interprets the pain. So now, opioid analgesics. They're really considered the first line of therapy for pain that's associated with procedures. Things such as like a bone marrow biopsy is one I can think of. That's a pretty painful procedure that we need to give a really good analgesic for. Pain due to trauma, such as burns or someone who's in an automobile accident. Pains associated with cancer, and pain associated with the internal organs, such as pancreatitis and appendicitis. Opioid analgesics are really what we grab onto first for this type of pain. They can pretty much relieve any kind of pain. A few of our opioids are also used in conjunction with anesthesia for their sedative effects. You may have heard of fentanyl or Sufenta, and we use those, even though they're an opioid analgesic, we use those to create an aura of sedation preoperatively in patients when we're going to use anesthesia. We do have some other opioids, though, such as codeine, hydrocodone, and dextromethorphan. You may have heard of some of those. and they are used widely to suppress coughing. Um, so if you've looked like some of your preparations that you'll use for um, nasal congestion and coughing, cough drops and cough syrups often contain codeine and or dextromethorphan because they're effective in suppressing those coughs. And we have another one, loperamide, which is known as Imodium, is also an opioid, and it works really good as an anti-diarrheal. So those are some opioids that we see used for other things than just analgesic preparations. Now, until recently, drugs that were extracted from opium, known as the opiates, or synthetic chemicals that produce the same pharmacological effects as opium, were called narcotic analgesics. Now, while the name really still applies to the laws that govern the use of these drugs, the current terminology, as we do change things as time moves on, for these medications are opioid analgesics. So you may hear them referred to as narcotics, but the current term or the current buzzword term for them is opioid analgesic, and they really are the same thing. Now, naturally occurring opiates are derived from opium, and that would include things such as morphine and codeine. Morphine is probably the largest component chemicals and is extracted from the poppy plant. So the term that we talk about when we talk about opioids today is really used for any molecule, whether it's synthetic or natural, that acts in the same vein as morphine. Now, tolerance and physical dependence are factors that really influence opioid use. Tolerance is that decreasing effects will develop with all opioids, and physical dependence will develop also with long-term daily use of the opioids. And so because of their potential for abuse, the opioid analgesics are federally restricted, controlled substances, usually kept under lock and key, and are monitored very closely, have to be signed out when you're in an institution working, and we limit them numbers that can be prescribed at any given time when they are being prescribed to be filled at an external pharmacy by a patient. The opioid analgesics are called central analgesics because they work within the central nervous system to reduce that reaction to pain. They really don't interfere with the function of the peripheral nerves. The pain is still there, but what it does is it regulates how the patients respond to the pain. So it increases their ability to be able to tolerate the pain. Pain is still there, but they have a decreased response to it, and so therefore they are able to tolerate the pain much more than they could without the analgesic on board. Now, that reduction in awareness and the reaction to pain is really controlled through several different receptors within the brain. Morphine and the other opioids act by binding to those receptors and mimicking the effects of the analgesic peptides. So what they do is they interact with the receptors at different levels in the central nervous system. Opioid analgesics may also influence central nervous system function by increasing or decreasing certain amounts of central nervous system activity. In particular, they can produce changes in mood and decrease mental alertness. So you've got to be careful. These are the ones that you're telling people that can't operate machinery. They shouldn't be driving a car, and that when they are taking these medications, because they do become less alert. Now, some people do say they feel a warm glow. We call this euphoria, and that's that high kind of a feeling that comes along with them. Some people, though, unfortunately, also can get what's called dysphoria, the opposite of euphoria, where they get very anxious and fearful on these medications. So you can see people go either way with these. They can either feel very good or they can feel very on edge. And it's not unusual to see one or the other with someone who has taken an opioid preparation. In low doses, most of them will produce some nausea and vomiting. So we do have to be aware that they do interact with that GI tract. And then it can also lead to constipation because it will slow that GI tract down. So patients who are taking opioids will almost always experience constipation. And once they go off the medication, the constipation will go away. The most important effect that we have to be aware of, though, of these medications is that they can produce respiratory depression, which means, and take enough of them and they'll make you stop breathing. So very carefully, when we have a patient who is taking these medications, we do have to watch the respiratory rate. And if we see the respiratory rate going down, we need to decrease the dosage or discontinue the medication altogether. Opioids are available for both oral and parenteral administration. Usually we see the parenteral forms used mostly in surgery and in post-surgery. Rarely do we see people going home on IV or IM opiates. The oral preparations we use to treat both acute and chronic pain, and where we frequently will see this is many of our cancer patients will take oral medications to help manage the pain associated with a variety of cancers. All those oral formulations, though, must, if they are in a tablet or a pill form, must be swallowed. You should never chew them because of the GI irritation stuff. They're frequently administered on a schedule. That means every 4 to 8 hours to relieve moderate to severe pain. What you're trying to do is establish a blood level of blocking that response to pain. If you go and you spread it out too much or take it intermittently, what happens is people get a great deal of pain, then it takes more drug to get the pain under control. They get it under control, then they get the sleepy, the side effects, and then it wears off, and then they go a while, and now they're in extreme pain again. They keep doing that rebound up and down. So best is to get on initially, to control that pain, is to get on a schedule, and then as the inflammation decreases, start decreasing or lengthening the schedule, or the the time between dosage, and gradually tapering it down. Recently, there's been, I have to mention that there's been a really significant change in the attitude regarding treating severe pain. In the past, we were very much afraid of using opiates because of people getting addicted to the medications. But that has really kind of changed tunes a little bit now. So we have specialists in pain management who are very aggressive in using opiates and getting pain under control and closely monitoring opiate administration in patients so that we can properly dispense the medications and keep the patients pain-free. which is a little different philosophy than what we used to use years ago. So generally the feeling is if someone's in pain, let's treat the pain. It may be a little higher dosage because of their body chemistry, but as long as our side effects are minimal, we will increase dosages and manage their pain. Now, because they are central nervous system depressants, as I said, we do need to watch them closely and monitor dosages and monitor the vital signs when patients are on these medications. And particularly, we need to be careful with the elderly who are receiving these medications. Indications of a decreased blood pressure or respiration may be due to the patients being over-medicated. And remember, our elderly in particular have difficulty in excreting medication, so their blood levels can build up, and they may not be metabolizing and getting rid of the medication as quickly as they should be. Eventually, the liver metabolizes the medications and the kidneys excrete them out. So whenever we have kidney or liver involvement, we need to monitor these medications and the vital signs of these patients extremely closely for increased elevation in their blood and developing toxicity to the medications. The adverse effects that we will see from opioid analgesics revolve around that of mental confusion, nausea, vomiting, dry mouth, constipation, and urinary retention. Keeping in mind that, again, respiratory depression is the very severe adverse effect, and people do and have died from the respiratory depression of opioid analgesics. We can't talk about these medications without kind of touching a little bit on some terms from back in the beginning of the course. Those are terms of tolerance, physical dependence, and addiction. If you recall, tolerance is that point where people require more and more of the medication to get the same effects. Opioid analgesics do develop a tolerance very quickly. People on opioids can also develop a physical dependence, whereby you cannot just take the drug away cold turkey. You've got to gradually remove the drug from the body because our body has become physically dependent upon it. And then, that physical dependence can also be associated with that of addiction. And then addiction's that much more complex piece that involves the genetic and psychological and socio-environmental factors that lead to behaviors where an individual just can't control themselves in regards to the medication. And again, there are cases where we do see this with our opioids or narcotics. Okay, off that topic and switching to our next category of analgesics, and that's called what we refer to, and a lot of people will call them NSAIDs. NSAIDs differ from the opioids in four different ways. First, they are not chemically or structurally related at all to morphine. Second, they are not effective against severe or sharp visceral pain. Third, they produce analgesia through both CNS and PNS actions. And fourth, they do not have an association with tolerance or physical dependency with chronic use. So they really are a total different category of medications for controlling pain than the opioids that we just talked about. The term NSAID refers to non-steroidal anti-inflammatory drugs. And the reason they're called that is because they are not structurally at all similar to cortisone, which is an adrenal steroid. And so they produce their anti-inflammatory action through a totally different mechanism than the steroids, and that's why they're called non-steroidal anti-inflammatory drugs. There's really three groups within this class, and they are the salicylates, the traditional NSAIDs, and the COX-2 selective inhibitors. And we are going to focus on the salicylates and the traditional non-steroidal anti-inflammatories. So first, the salicylates. Our main salicylate is aspirin. Aspirin is probably one of the oldest and most frequently used analgesic drugs. It is known to be analgesic, reduce pain, as well as to be antipyretic, reduce fever, and an anti-inflammatory. And a little bit of history. Salicylates were discovered many centuries ago as a natural product of willow tree bark. The fact that Native Americans made teas and drank beverages made from the willow bark to relieve things such as headaches and toothaches. And today, we still use them, particularly in the form of aspirin. And we also have some others that you might not be aware of, such as methyl salicylate, which comes from the oil of the wintergreen tree, Bengay, and deep heat, that are salicylates that you may have also used to help treat and manage pain. Now, as we said, salicylates produce both analgesia and antipyresis. And how they do this is they affect the hypothalamic center of the brain, which reduces an elevated body temperature. But it doesn't affect, interestingly, it doesn't affect normal body temperature. It will only reduce an elevated body temperature. And aspirin is a potent inhibitor of prostaglandins. And as a result, prostaglandins are what cause inflammation in the body. So as a result, when you decrease inflammation causes pain. So if you inhibit prostaglandins, you will decrease inflammation and therefore also decrease pain. So that's kind of a double duty, in that the inhibition of prostaglandins will decrease inflammation and subsequently also add to the analgesic effect of the medication. Now, aspirin, in addition, has another benefit that's of therapeutic significance, and that's the fact that it will reduce the risk of death and reinfarction following a myocardial infarction. Low-dose aspirin daily lowers the risk of heart attack and prevents heart disease and a second heart attacks in women and men over the age of 65, and pretty much in men at almost any age. So we also see, and particularly the one that you see pictured in the corner here, those low-dose chewable aspirins used in the prevention of myocardial infarctions. Now, the downside of aspirins is, though, they do directly irritate the stomach lining, which first off can cause nausea. Now, over time, though, because their effect on prostaglandins also help release bicarbonate, which protects the mucosa in the stomach lining. So when people take aspirin and decrease prostaglandins, they will decrease that protective lining in the stomach. And when you decrease the protective lining in the stomach, you can end up with gastric ulcers. So the GI effects of aspirin is something we really have to watch out for. Our next category, our next medication we want to talk about in this category is that of acetaminophen. I have pictured here Tylenol, but there's many different brands now of acetaminophen. And acetaminophen is often considered really to be an aspirin substitute. However, that's not totally correct, because acetaminophen will produce analgesia for relief of minor headache and some antipyretic effects, but it really doesn't have any proven anti-inflammatory activity. So it doesn't have the decrease in inflammation like aspirin does. Acetaminophen is basically approved to reduce fever, headache, minor musculoskeletal pain, and discomforts, associated with your common cold and your common flu. And it's really useful in patients who are allergic to aspirin and those who are receiving anticoagulant therapy because they can't take aspirin because it will potentiate their anticoagulants, or for patients who have upper GI disease such as gastric ulcers or gastric irritation, where aspirin is not an option. But again, remember, it's only going to be good for analgesia and for bringing down a fever. It's not going to be good it's not going to have any anti-inflammatory effect for those people. It's also widely acceptable for use in children, and as a result, you see it available in so many different forms. It comes as elixirs, it comes as suspensions, it comes in a syrup, it comes in popsicles. All different dosage, all different formulations are available of it without a prescription. So now, although it is remarkably safe when it's taken in recommended doses, don't think of it as just a harmless drug that you can just take any time. You can get toxic from chronic usage of large doses of acetaminophen. And that would be, more than 4 grams a day in an adult is what we're talking about. You can also have an acute overdose from a single ingestion of a large dosage of acetaminophen, and there have been deaths associated with acetaminophen overdose. So it is not without its difficulties. Now again, all the non-steroidal anti-inflammatory drugs may produce some nausea, some GI distress, and some ulceration. The most serious complication of that ulceration would be a massive hemorrhage if the ulcer decides to bleed through. But also you need to keep in mind that we do discourage use of NSAIDs in the elderly, and there are some new guidelines regarding the use of these medications in the and the guidelines for the elderly include that every over-the-counter product containing an NSAID should include a bolded warning against consumers about the potential risks for severe stomach bleeding, especially in people who are over the age of 65, have had stomach ulcers or bleeding problems, who are taking a blood thinning or steroid drug, taking other prescriptions containing NSAIDs, or have 3 or more alcoholic drinks a day while using the product. So though people tend to go, take these over the counter, it's over the counter, it's harmless, they need to be very well aware that there can be some serious side effects of these medications. So you should start and keep your eyes open for that particular labeling coming across on your nonsteroidal anti-inflammatory medications. So in a nutshell, if we're looking at our medication or not our analgesics, the different ones are preferred for different actions, such as aspirin. Aspirin is most effective for the relief of fever, headaches, and inflammation of any nature, which includes arthritis, and is also indicated for the prevention of heart attack or stroke. So in these cases, aspirin would be the drug of choice. Ibuprofen and naproxen are frequently used to relieve kind of the aches and pains kind of stuff and inflammation, but not as effective against fever and headaches. And the last, acetaminophen, is really the preferred drug for reducing fever in aspirin-sensitive patients or in children who have viral infections, because we know that aspirin can lead to something called Reye syndrome. So we would want to use acetaminophen in those cases. It's also effective against headache and is readily used as an aspirin substitute for people who cannot take aspirin. However, remember the inflammatory effects are not there, and has no effect as far as prophylaxis of heart attack or stroke. And with